Thank you again. So this is the session 4 of our EMPART training, and we will talk about today access to care and patient navigation. In fact, we would hear from Dr. Shilpa today in a little bit. And hopefully this would also be a useful session for you guys for as compared to the previous ones that have gone in, and hope you could get more out of it. And again, please, by all means, put your comments in the chat button, ask questions if there is a need. If something doesn't jive well, let us know what's not making sense, and so we would definitely, it's not that we are all clear all the time, but it would really help us as you provide the feedback. So our guest speaker today is going to be Dr. Shilpa Venkachalam. She's Associate Director, Patient-Centered Research. Maybe perhaps Dr. Rebecca would introduce her when we would be ready to talk to her. I think it's she's on the call, but I think it's about in a few minutes she would come in, I believe. So today's topics are basically, we are going to meet Dr. Shilpa, the health coverage basics, managed care, federal poverty levels, eligibility criteria. We would walk through what puts people in what kinds of healthcare brackets, and of course, tax brackets and insurance tax credits. So now today, I'm going to ask Brother Abdurrahman Bahri to start with a prayer.
Assalamu alaikum, everyone. So we'll start off with a very short prayer. Bismillah ar-Rahman ar-Rahim. Allahumma inni as'aluka min al-khayri kullih, ajilihi wa ajilih, ma alimtu minhu wa ma lam a'lam, wa a'udhu bika min al-sharri kullih, ajilihi wa ajilih, ma alimtu minhu wa ma lam a'lam. And a brief translation of that is, O Allah, indeed, I ask you of everything of good, the one to be hastened of in this world and the one to be delayed in the hereafter, from that which I know and I don't know, and I seek refuge from every kind of evil in this world, and to be delayed in the hereafter from that which I know and do not know. Ameen. May Allah accept.
Ameen. Okay, so we're going to touch on some of the basic core competencies today. Would be system navigation, and a little bit more towards community engagement, and of course, coordination services would be pretty hefty in terms of patient navigation or access to care. The skills that we are going to touch up today would be ability to provide informal counseling and social support, the ability to identify and access resources, ability to coordinate services and care, ability to make appropriate referrals, ability to respond to questions about a variety of topics, and most of this is happening in the context of access to care. And ability to participate in individual and community assessment, knowledge about U.S. health and social services systems to be continued, and of course the professional skills are coming along as we provide the services to people. One of the things I would also like to emphasize, and we don't do this every session, however, we did this in our introductory session, but these are some of the basic community health worker professional qualities or traits. However, the reason why I want to present this is because this is actually the characteristics of a leader. I was told that my slides are not being shared. I forgot to share my slides. Sorry about that. And you guys must be thinking, what is she talking about? So let me start from here. Okay, so we have, so this is the beginning. Today's session, Dr. Shilpa would be coming in. This is today's topics, prayer, and then we went through the core competencies, skills of a community health worker, and now we are at this okay. So just a second, I lost some connection. Okay, sorry about that. Okay, so these are the 21 characteristics that I have actually encountered where these are the qualities of not just a community health worker or a researcher, but it's the qualities of a leader. So if you want to be a community health leader, these are some of the things that you would want to cultivate within yourself. A long time ago, what I did was there was 10 basic qualities of a leader. I actually wrote it down or printed it out, did something, and I posted it where I could see it every single day. And that really helped me a lot. Some of the things which I wanted to cultivate within myself, I actually, it helped me to look at it every day and kept a reminder. One of the another things that you could do, it's completely out of the scope of this, but towards the leadership, 7 habits of highly effective people. And you could actually type or write up those 7 habits, just the names of it, and put it right beside it. It really helps a lot. So anyways, let's move on to the review. So I just want to have a basic review first of what we have been covering so far, and our main focus is facts about health equity and health disparities in communities. So a healthy health disparity is a health difference that's avoidable. That's the key, unnecessary or unjust, and that's what we're trying to do to eliminate or dissipate these differences in health outcomes based on population groups. There shouldn't be these kind of differences. Differences in disease prevalence based on population groups. Dr. Rebecca Johnson did a wonderful job in covering life expectancy and some of the conditions related to life expectancy yesterday. Worse health among socially disadvantaged groups. We actually saw that as we saw different zip codes yesterday. Access to care is dependent on social class. You're going to actually see that today, how we have been there is systemic categorization of within healthcare, and you'll see how it is actually putting people into different classes. Differences in access to care create health disparities, and that's what happens. We have seen that maybe perhaps in the next few sessions you would see the differences in the outcomes between Medicaid patients and Medicare patients and the private insurance patients. And we all understand this, we know this exists, but what do we do about it? That's the key. Why should it be differential to different kinds of people? Now I'm hoping that Dr. Shilpa would join us now. And Dr. Rebecca, would you perhaps be so kind to introduce her?
Yes, no, I'd be very happy to. So thank you, Fatima. So as you know, when we met before, we were talking. One of the things we also went through were the patient-powered research networks. You know, PCORI is sort of the alliances that PCORI had been putting together of patients to address some of the major health conditions which had been coming out of the big data. So I'm really pleased to sort of introduce you to Shilpa, who is the associate director. I think she'll talk a little bit more about her role at Creaky Joints, which is one of the PPRNs that I pointed out yesterday as what, from my perspective, is a really good practice PPRN. I just feel all the time, and I hope you agree when you sort of have more time to look through the website, that it really is building on lived experience and to improve the lives of people with chronic disease. Through better access to care, education, support, advocacy, and patient-centered research. And Shilpa has been very generous and very kind and supportive to Pastors for PCOR and the Research Ministry ambassadors who were interested in chronic disease, and has yes, has been a good friend to all of us. So without more ado, I'd like to sort of introduce you to Shilpa to talk a bit more about the about this patient-powered research network.
Thank you very much, Rebecca, and thank you, Fatima. Your group, I've heard a lot of wonderful things about your group, and right at the start when I joined, it just the energy was really something. So thank you for having me join you today and giving me this opportunity. So I know I have about 10 minutes, and I would love to engage with everyone even after. And you see my email on the slide, so please feel free to contact me. But I'll just give you a very quick overview in the context of PCORI and our long relationship with PCORI as well. So I work for an organization called the Global Healthy Living Foundation. They're popularly known as creaky joints. And as the name suggests, we deal with all things creaky joints. So different forms of arthritis, autoimmune types of arthritis, but beyond that, also just rheumatic and musculoskeletal conditions. In fact, I myself, I'm a patient as well as a researcher, so I wear two hats. I live with rheumatoid arthritis myself. So, this work, and this happened to me after I joined the organization, just by the way. So, this work has both a personal as well as a professional commitment for me. So we can go to the next slide, and I can just give you an overview of the organization. So as an organization, we do, we're sort of, we have 4 arms. So we're very closely linked to anything that's community-based, right? So and by community, I mean both in-person as well as virtual, as many things are these days. So we do a lot of education and awareness building. That's one of our main things. A lot of chronic disease populations of patients I think can benefit more from knowing about their conditions and what to ask when they go and see their doctors, how they can be involved in goal making and goal setting with their healthcare teams, etc. And so the first step is to build awareness and not so much empower them, because they're already empowered in so many ways that we don't know ourselves, but to sort of, join them and add to the knowledge base that can support them in informed decision making. In addition to that, we have a community, an online community, and actually, while Global Healthy Living Foundation is the parent organization, so we deal with a lot of different kinds of chronic diseases. One of our online communities is called Creaky Joints, and Creaky Joints is an online community of patients living with all kinds of autoimmune conditions, autoimmune forms of arthritis like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, lupus, and they derive support. So it's a network, really. It's an online network and community where patients are able to draw strength and share experiences with each other. That's the community building part of the organization. We also do a lot of advocacy. Of course, there's no community work without advocacy. And so, what I think what we always tell patients, and what I always tell patients, other patients, is when you're advocating for yourself, you're also advocating for your community. Never forget that. So we place a lot of importance on advocacy. And the first, first step of advocacy is making your voice heard. And so a lot of our activities are advocacy related. And then what I do a lot is something called patient-centered outcomes research, where the patient is as important a stakeholder, if not more important, alongside clinicians and researchers. And one thing that I always tell patients when we're talking to patients is a lot of patients ask us, well, what can we bring to the table? Clinicians, researchers, you guys study this, you guys know this. And the whole push, I think, behind PCORI as well as the work that we do is that the experiences that we have as patients, no one else has. The doctor doesn't have those experiences, nor does the researcher. It's the patient who lives with the disease day in and day out. And so that information can only be coming from the patient. And that's really an important piece of the puzzle to understand any chronic illness. And so that's what patient-centered research is, to bring the patient, so to speak, at the center of the table. So we can go on to the next slide. And please, feel free to stop me if you have any questions. You're certainly not interrupting. I'd hear from you all as well. So I think Rebecca had spoken yesterday about, or you all had a discussion about the patient-powered research networks of PCORI. And that is how Arthritis Power was set up initially, with funding from PCORI, the Patient-Centered Outcomes Research Institute. We partnered with the University of Alabama at Birmingham, so with clinicians and doctors and with patients, most of the patient-powered research networks within PCORI are patient-driven and patient-led. So, traditionally, many years ago, maybe 10 years ago, research was always done by sort of, I guess a club of elite few people who had, say, a PhD behind their names, right? And that's great. And, we're not discounting that. But alongside those people, there is someone whose voices we need to hear, and that is the patient. And so every patient-powered research network has a patient investigator alongside the clinician or the researcher who is also the principal investigator. And that's what Arthritis Power is. It's a patient-powered research network. You can download it on your phone. So it has a dual function. You can use it as an app to track your disease. So for example, if I've started a new medication and I want to track how my pain is doing after I've started that new medication, I can use Arthritis Power to track my symptoms, to make notes about my disease, so that when I go in to see the doctor next, I can share with him an important piece of the puzzle from my own experience and help advance what the doctor is understanding actually about the disease itself. So that's one piece of Arthritis Power. The second really powerful and interesting thing, and something that always sort of excites me is, when you're understanding a disease, you understand a lot from scans and X-rays and blood work. But there are certain things that just don't show up on a blood work, that just don't show up on a scan. So a lot of chronic diseases come with fatigue, for instance, and there's no biomarker, there's no blood test to measure fatigue. But there's one person, the patient, who can tell us very important information about fatigue, which is studied very closely in chronic diseases. And so a lot of these patient-powered, Arthritis Power, for example, the patient-powered research network and registry, has a way of measuring and recording things like fatigue, pain, depression, anxiety, things that are not regularly seen on blood work and scans. And these actually are very scientific measures. We often think about these things as, oh, this is subjective, etc. And they are subjective, and you should never discount the importance of subjective information. But they're also objective measures, because the National Institutes of Health, the NIH, developed something called the Patient-Centered Outcomes Measure Instrument. And that is what we use for our registry. So we have these measures that were developed by the NIH so that patients could record things like, how they're faring on their fatigue or their pain, etc., to track their disease and to give a bit bigger and better picture to their clinician. So this is what is interesting now. So all this time, we've been talking about how patients track their disease, how they can share that information with their clinicians to make decisions, how they can share that information with their family and friends. Often these diseases are invisible, right? Nobody sees pain, but you feel it. So, you might look very well, but you might not be feeling so good. And so how do you share with the community? Because as part of sort of advancing research is also sharing with the community what you've learned, right? And so this is something that we pay a lot of importance on. And so this is the health picture that you derive from the patient-centered, the PPRNs, or the patient-powered research network, is a combination of clinical data as well as these patient-reported outcomes. These are called PROs, or PRO measures. And these are patient-reported outcomes, what comes directly from the patient. And that is what we collect. All the time when patients are doing this, they've consented to sharing this information very generously with researchers. And so researchers are studying this information to understand the disease itself. So what researchers are in essence doing when we partner on a research project, what we're actually doing is we're combining clinical data and we're combining very important information that we're getting from the community of patients to understand a disease better and in a more fuller manner. And so really, as a thank you, because this is something that patients are doing of their own choice, right? We place a heavy importance on going back to the community, always going back to the community and sharing what we've learned through our research back with the community of patients. And I keep saying community. We are the community. There's no us and them here. We're all in this together. So researchers, clinicians, patients, we're all stakeholders and part of one goal, which is to advance research in whatever disease we're working in. So that's a little bit of Arthritis Power. Today, we have currently over 28,000 patients who have registered with Arthritis Power, and we do very many different activities with them. We can go on to the next slide, please. This is just a very quick overview of the different conditions that we have within Arthritis Power. So you can see the different diseases, and we do different activities. So for example, we'll do educational webinars with our patients every once in a while. This is mainly to share back with the community cutting edge research in terms of what we're learning new about a disease, etc. So I think I keep coming back to that word that you all have been, I suppose, keeping at the center of your discussion is the word community, right? We're all in this together. And so we keep going back to the community because in some ways, as researchers and clinicians, we're also asking a lot from the community. It's not easy for patients who are living with a condition to constantly be providing information, but they're doing it anyway because they're doing it sort of keeping in mind the larger good, right? How are my children going to live with this disease, or how is the next generation going to make advances in this disease? And so that is the impetus behind them contributing. And so it's our duty, if nothing else, to go back to the community and share with them what we've learned from their own information. So we can move to the next slide, please. This is just to give you a very sort of broad overview and look at what the app looks like. So you can track your disease. You can see how you're doing over time. That's what analytics is about. So, how was I doing in before the pandemic versus after the pandemic? I guess we're not after, but, sort of during the few months down into the pandemic. You can share your results with various people, whether that's your family or with clinicians. There's a lot of impetus, I've told you, on education. And then, of course, there's research opportunities. So this is really important. Community building means, for us, asking patients not just to participate in research, but to participate as consultants and advisors when we're designing research studies, right? So this is how we make sure that patients are equal stakeholders in any research project we do. We don't just go to patients to ask them to give us data. We go to patients because we want to understand from patients, well, what is important for you to know as a patient. So they become equal stakeholders. They become advisors to us and consultants to us. So this is just, again, an overview of Arthritis Power, and I'd be happy to answer any questions that you have at any point later on. And then we have, I think, one more slide here. So one of the things, there's so much to talk to, and this is such a wonderful group that I could spend an hour talking, but I won't. I'm very mindful here of the time. But when the pandemic started, a lot of people who were living with chronic underlying conditions had a lot of concerns, and they asked us, about various different questions about living during this challenging time when there was an emerging virus that we didn't know very much about. We still don't know very much about. And so this is an example of how we allow patients or the community to tell us what is required. So based on patients asking us, questions and concerns, relaying their concerns, we developed a support program a free support program for patients living with all kinds of chronic illnesses, called the GHLF COVID-19 Patient Support Program. And you can see the different conditions that participate, in patients with different conditions participate. The main goal here is, again, community building, just to let patients know, patients who are living with chronic conditions across the country, across the world, let patients know that you're not in this by yourself. At the worst of times, we're with you. We're here to provide support, education, and what have you. And so we allow patients to tell us what they need information about, always stressing that we are going to provide reliable, evidence-based information. Because I think, one of the important things about community building, community leadership is responsibility. So what we share, we must share responsibly. So we share evidence-based information back with the community so that, again, they feel more equipped to make decisions, whether that's with better management of their own conditions or with things around the pandemic. So this is just a sort of a snapshot of the Global Healthy Living Foundation. I'll stop and pause and see if anyone has any questions at this point. But, just again, thank you so very much for allowing us to speak here in this forum. There's so many synergies. In fact, Fatima, when you were talking right at the start, and I'm very grateful to Rebecca for introducing us, I would love to connect with your group and with you a little later afterwards. We're doing a lot of work on inclusivity and making sure that everyone's voices are heard equally. So we'd love to connect with you further as well and see if there's potential to have more conversations like this one. Thank you very much.
Oh, thank you so much, Dr. Shilpa. It was a wealth of knowledge there. I'll definitely have other people if they like to ask a question, but wonderful information and your insight into community and the patient as a stakeholders is really, I don't like the word using phenomenal, but no less than that, because that's really, having the patients as providing the input and turning that input into evidence is something extremely important. And without that, science is not complete. For a very long time, we have been neglecting that as researchers, and as the scientific community have been neglecting that. So thank you very much for sharing all that, and especially the wonderful work that you guys are doing.
Thank you very much. Thank you. You guys are doing amazing work too. So we draw inspiration from groups like yours. Yeah. So thank you for having us.
Energies out there. Anybody would like to, and I don't know if Dr. Shilpa is going to stay with us for much longer, or if she would attend the whole session, but please do put your, ask a question, and I'll give you a minute or so, or put it in the chat box.
Hello, Dr. Shilpa. Thank you very much for the very informative and wonderful explanation of what GHLF does. I had a question about the app, and how many people use the app, and do you have data of the patient age that use the app? Because I know older patients have problems usually accessing technology, and how are you addressing this?
That is such a good question. Thank you for asking that. Yeah, so we have currently 28,000 patients with various different conditions. Generally, a lot of, so there's a different age group for different diseases. We see a lot of middle-aged women with rheumatoid arthritis, and then slightly older age demographics for osteoarthritis, and then very young people with autoimmune diseases like lupus and psoriatic arthritis. So there's a variety of ways we, I suppose there's a variety of ways in which we share knowledge about the app, I guess is the best way to say it. To your question, for older populations, we do understand that there might be technological challenges and competencies to address. And so, for example, we have, as Rebecca had earlier mentioned, we've worked with pastors for PICOR. We were invited to speak in a church, for example. We stayed on a little later so we could help people navigate the app. We've also spoken in a few senior centers and gone into senior centers and sort of done a one-on-one navigation training for the app. So there's, in terms of community outreach, there's so many different ways. I think the younger folks, the 20-year-olds and the 30-year-olds are more comfortable with technology. A slightly middle-aged group is sort of comfortable with both because they've seen a world without technology and with, so easy to speak to them in so many ways. And then the older, slightly elderly populations, we meet them where they need. So, we don't go in saying this is what we should do. We ask people, what do you think are the challenges, for you to use this app? And what can we do to make it easier for you to use this app? And that's what we're actually in the middle of doing. We've just received a PICORI award to do exactly that, actually, to build our community and include more diverse populations. And so as part of that, we're engaging senior centers, senior assisted living centers, etc. So I hope that answers a little bit of your question. But thank you for that. That was a great question.
Yeah. Thanks, Asim. That was a bit, that's where we were struggling with too, during COVID and virtually attending to patients in many different ways. I hear this from many different nonprofit organizations. Absolutely. It's definitely a big barrier. Anybody else? Okay, let's thank you again, Dr. Shilpa, for beautifully connecting us with from the grassroots levels. You've actually connected us to the comparative effectiveness research through the PPRN, and this is really, we talked about this a day or two ago, from the big picture where the comparative effective research and innovation, as you see up on the top, you got the translational sciences from NIH or NIH's databases, you got CMS.gov and PICORI. They all are the means and vehicles for the comparative effective research. And then they get these data from what Dr. Shilpa was talking about, the PPRNs. They collect this patient databases, and actually these come to all the way to the, when they go to the doctors, they are going to the ACO and the providers right there. I want to see if I can have my pointer. Tools. I think right there. Oh, I don't know. Where did the pointer go? Anyways. Yeah, I don't know. Oh, here, the pointer right there. So the pairs are right there, and these are the insurance pairs. So when any patient is actually goes to the doctor, which is now the ACOs and the healthcare providers, they have become accountable care organizations. Then that particular physician is actually asking or billing from the pair, so that data is actually transferring to the pairs, as well as that clinical data is, and as well as the billing data is going to the CMS, to these databases out there. And of course, the AHRQ is getting the patient data as well as the billing data too. The pairs are also sending the billing data to the AHRQ, and this is where we're actually matching up the cost quality access. The triangle is coming together with the AHRQ, and we are looking at where are the health disparities, so these patient databases are extremely important, and this database is really a tool if you think about it. So if no information goes in there, how is that AHRQ going to know if the health disparity exists or not? No one will know that. So having patients inputting this data, especially if they are doing it as they are living through the condition, having that living experience transforming on a day-to-day basis into a database. Think about it, the wealth of information we are going to capture from that data, and the wealth of information that would actually come out in terms of comparing that to cost and comparing that to clinical treatments, and what treatment would work and what treatment doesn't work. And this is exactly what the goal of comparative effective research is about. What works and what doesn't work. And PCORI has the same hat, Translational Sciences has the same hat, CMS has the same hat. In fact, AHRQ is PCORI's official disseminator and mission distributor. So AHRQ is collecting this data to disseminate into the community and to make use of this in terms of cost and quality. So this is the way the data goes from payers to the AHRQ is the all payers claims database. This was also a part of Affordable Care Act, by the way. This entire picture that you see, all the connectors that are happening became these connectors as a part of ACA. So we are literally living and breathing ACA today, 10 years into the implementation. So it's an amazing piece of work, and I have personally seen it coming together and unfolding in front of my own eyes, from health disparity policy to implementation, that it's been about a 30-year journey, and it's been an amazing piece of work, and how this all has come together. So let's take a look at the all payers claims database. Oh, by the way, I want to introduce a concept of, you see that there are different insurance payers. You've got Medicare payer, you've got healthcare.gov, you've got insurance. So one of the things that we will encounter even later on today would be that this concept of HMO versus PPO, and you all have heard about it. An HMO may not allow you to do a lot of things. The PPO, you have your will, you can go anywhere, but all of the HMO and PPO's data are going into this. And what happens is there are very subtle differences between HMO versus PPO in terms of clinical the delivery of services, but when it comes to the actual health delivery, they relatively are the same, but the outcomes do tend to matter a lot. So as you see over between this and this, you can simply, my slide is not that great, but if you just look at it, you've got 7 measures here, and you've got about 5 measures here. So there are basically two different measures that are missing out of it, which are the specialty cares out there. And what PPOs allows in terms of your extent of services versus HMOs. Now, but HMOs are great in maintaining a population health. So they take a big population of people or communities, and they make sure that everyone in that community is getting basic benefits to the par level. Whereas HMO, it's up to you or PPOs, it's up to you if you want to really go to that. You're in charge of your own health, whereas in HMO they are trying to be on top of the population health, so they keep a better eye, or they have more of a critical eye on the patients, whereas in PPO the patient is really having their own responsibility of keeping an eye on themselves. So let's talk a little bit about how these two kinds of differences, or the different pairs, end up where. You saw that the pairs, the pairs out here, there's all payers claims database. So if you go to the AHRQ's website, I'll tell you, you would end up right here. This is the all claims database. Now, remember, the AHRQ actually had a policy memorandum under ACA back in 2015. We talked about that a day before. This is what came out of that memorandum. And AHRQ has has pretty much this entire database open to public. Of course, patient information, PII, is hidden, but you can compare different, for example, HMOs versus PPOs. You can compare the Blue Cross's data. You can compare different kinds of data and who's charging what, different health conditions. And it is by state, actually. So some states, for example, no current activity. So existing, the black is existing, the blue is existing, the black is in implementation, and you have the lighter blue as in existing with voluntary submissions. The darker blue is a strong interest and existing voluntary effort and no current activity. See, Illinois has no current activity. And so our all payers claims data is not really being populated to the extent where it needs to be populated. I'm sure some of the insurance companies are sending because they are mandated to, but it's not every claim is going in there. Not all insurance companies are following the same protocol, and that's what needs to happen. And this comes down to policy measures. We mandate insurance companies to actually share this kind of particular data so we know how much they are spending. So with the big picture, it matters a lot. So if you go to the AHRQ's website, you can go to the All Payers Claims Database. Right there, it says, if you click on that, it comes to scroll down, and it will open up this particular website. And there are a lot of there are different things, database release rules, collection rules, and dig deeper into it. But there are publications out there, resources out there. Guess what? Every single thing about research is out there on the network today because of ACA. And it doesn't really mean that I'm promoting ACA, but prior to ACA, I personally know I had to go to libraries, dig much deeper into any if I needed to talk about or know about any of the conditions or how it's happening in a particular state or in particular hospital. Oh my God, we went through hoops and loops of just to get to the material. What the material said was something else, but the amount of time we have spent, and therefore there was a distance of about 30 years from the time the research came in to the time the grassroots was affected. So this has brought in a huge tremendous improvements into how we can use the current research with the patient power networks and with all of the different tools and elements out there. That comes back to resource, tools, and methods. So now we are literally, if you look at it, we are right in the middle. We are looking at mainstream, and we are connecting to grassroots levels. But again, I want to take a pause here, and I want to ask, for what are we connecting? What are we doing? Do you guys remember? Put your comments in the chat box. What are we doing here? Anyone? Mapping came from worry-free community. So one of my people put in. What's happening, guys? So what are we discussing here? That's what I want to know. Okay, let's go back. So remember, we started with anybody? No, people are lost, I guess. Okay, so before we started, we talked about facts about health equity and health disparities in communities. That's what we are trying to do. We're trying to look where disparities are, what can we do about it, and how can we eliminate that? That's what we're looking for. So Dr. Shilpa talked about the different arthritis, and she talked about all of those different diseases. And these diseases do exist in the different communities have different prevalence of this disease. I'm very sure about it. We don't have that data presented here, but if you look deeper into different communities, these chronic conditions are actually mapped differently on different communities. So that's what we are trying to look into. If does arthritis affect differently in different races, with different ethnic communities, and or what are the different health conditions that are affecting or that are showing up as comorbid conditions in different ethnic groups. So this data is being collected right here. And why are we collecting all of this data? To work with health disparities, right? Okay. So that's what we are doing. And again, these are some of the things which I think we want to hear, and we want to get to know more about it. Health disparities, health factors, social determinants of health, translational sciences, AHRQ databases, PPRNs, PCORNet, and you would have a quiz about PCORNet, I'm telling you. Okay, so how do we achieve healthy communities? Remember that Dr. Rebecca talked about this yesterday. We're going to talk about access to care, because now we know that not everybody has access to these patient-powered databases. Not everybody has access to the physicians or the ACOs or the healthcare providers. But I want you to look at healthy behaviors are at 30%. So healthy behaviors contribute 30% to health disparities. Clinical care, and this is clinical care, what happens with the doctor. Access to care is a big piece in there. You can even say 50-50. So clinical care contributes about 10% to where they go. So getting to the doctor is 50% of getting treated. Just getting to the doctor is 50% of being treated. And then you have the treatment. So quality of care really contributes 10% to health disparities. So we cannot say that, oh, because the doctors or the clinical health system is like that, that's why there's a health disparity. No, the health disparity is there not because of the clinical care, and the treatments are there. They're beautiful treatments and huge number of different kinds of comparative effectiveness research of what works and what doesn't work is there. But how much of that is really being used? That's why we are having the health disparity. And the reason why the clinical care is not being used is because of all the barriers that are there. There's health behavior barriers. There's access to care barriers. There's quality of care barriers. There are social and economic factors. Those are the barriers out there. And social and economic factors makes a huge amount of this 40% really is a maker or a breaker, and you'll see why. So remember, again, a review, the social determinants of health. There are 5 of them. This is the 5 that we're talking about. They're very similar, which actually determines the health outcomes. And CDC is mandated, as you remember, per ACA, to actually get the list out every year. They review the list, and they would either adopt the same list or they would modify it a little bit. I remember 2 years ago, we actually had 6 measures. Now we're down to 5 because they have taken the 6th measure and distributed them between social stability and social and community context. So understanding your patient. So when you are in the community and when you are trying to work with one particular patient, that's what happens when you go to the grassroots level. You have one person who comes up to you and asks you that, this is my question. So what are you trying to do? Or when you go into a community or your own community, for example, you're trying to understand and make sense out of where this community lies, and so you look at it and you say, okay, how do I make sense out of this? These are some of the questions you can ask. Do they share? Who are the people who work and live there? Do they share anything in common or belong to a certain group? Do they all have equal access to care, or certain folks have more access or less access? Do they share a common understanding of health, and does it affect them? Does it, under their understanding, hinder or speed healthcare interactions? All of these kind of questions affect how you support that particular community. And we talked about Dr. Rebecca took a poll yesterday as to what do you consider a community? So when you are serving your community, these are some of the questions you should be asking. And now going back to the grassroots level, this is where we are. Now we're focusing on the person, serving people for access to care. So we're going to now cater to that triad of healthcare. You had cost, quality, access. So we're primarily at this point, for the next half hour or so, or 40 minutes, we're primarily going to look at access to care. Now, before ACA, you had CMS.gov, Medicare.gov used to be there. But after ACA, there are certain things that really came about. And I'm going to try to finish up as much as I can in this particular, but knowing that, people are not very engaged at this point, I want to cover lesser amount today, and give more questions probably, because I want to make sure that everyone is on the same page of the understanding, because this is very important. When you go out in the community, you got to know what you're dealing with. You got to know who you're dealing with, and you got to know how you can help them. So all of these questions are extremely important, because no matter what kind of a profession you go to, data is going to be your secretary. Literally, data is going to be your professional secretary. The name, what comes to my mind? Actually, the Next Generation from Star Trek, where data was the thing. Hey, data, did you do that? Or hey, data, what about this? That's exactly where we are going to. I wonder if have anybody seen Next Generation of Star Trek, by the way? Can anybody answer me, or however many people? Who of you are familiar with the Next Generation Star Trek? Okay, so there was a series of a Star Trek, The Next Generation, and definitely it predates all of you, but that used to be my favorite series, by the way. And there was a character in there called Data, and that was his name. And it was a robot, actually. So, but that Data was actually the secretary for everybody, and he had things on his fingertips. And that's such an analogy with this, what we are dealing with, because I'm just reading through the comments here. So data is really what helps us light the path of our journey for our career. And especially in this day and age where we're virtual, this particular mode of action is going to be the norm in the coming years. So we have to rely on, and I was just very surprised to see, in fact, and very, very pleased to see that the amount of people that the Creaky Joints have served are 17,000, and the subscriber are 27,000. Beautiful. It actually tells you that that's the kind of N they are dealing with. In every research study, we have an N. What's the N? Which means the number of subjects that were there. So what's the N that we are dealing with? The N used to be 30, or that's a statistically significant sample size. 100 is really a good one. But if you have 30 subjects in any of that is considered statistically significant. However, in the virtual age, I would not be surprised if that number of a statistical significant comes out to be much higher than 30 and almost jump up to either in hundreds or thousands, because that's what we are dealing with in comparative effectiveness research. So, but the amount of data that you would collect from the grassroots you have a big gap to bridge there. You got to know who your community is. You got to have tools and technology on your fingertips that you can deliver and collect that data. You probably are one of the generations which you will need to lead you would be leading the actual invention of these tools. So all of this stuff is extremely important, and I would seriously support that if you do engage in understanding these big data, the big picture, it would be really beneficial for all of us, because you're going to be the next inventors of the tools coming up, guys. You will be the next inventors, and I'm looking forward to it. So going back to what ACA gave us, ACA gave us Medicaid versus Medicaid expanded Medicaid. So I'll tell you in a bit what it means. Private health insurance versus marketplace plans or Obamacare plans. Employee plans versus SHOP. Traditional Medicare versus managed Medicare. So there are ACA literally for access to care. ACA made a dent in every single aspect of access to care. One of the things which is still stands as is, but it has actually made a dent in as well, because pre-existing conditions was a big challenge for the people who opposed ACA. The employee plans, which is about 150 million people, are actually insured under the employee plans. So those people, the pre-existing conditions really went away. So the employers had to offer a much larger insurance umbrella to their employees. So ACA even helped with that. But the SHOP is primarily for the small business owners, which is 50 million or less. Okay, so let's take a look about how did the marketplace at work works. The health insurance exchange, the marketplace, is actually it is an exchange online. So people, it gave us two choices. It gives us choice for the individual and for the shop. Both of them are on there. Several insurance companies compete for business. That's how it works. Marketplace offers choice of plans. It offers 4 different levels of coverage: qualified health plans, essential health benefits. I'm going to explain this in a little bit or as we go. So one of the hallmarks of marketplace health plans was actually essential health benefits. And this is one of the things that are going into the courts right now, because that's what insurance companies are really fighting for, that ACA mandated that if you want to sell your plan or your insurance on the marketplace, you better have these 10 essential benefits offered in your plans. Otherwise, we will not accept your plan on the marketplace. You will not be able to sell it to the public. And one of the other things that it mandated is that the insurance companies have to spend 80% of what they earn from the insurance dollars back onto the people. And so so they can support all of these 10 essential health benefits: doctor's visit, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse disorders, prescription drugs, rehabilitative services and devices, laboratory services, preventive and wellness service, and chronic disease management. It's a basic service. Pediatric services, including oral and vision care, that's also part of the 10 essential health benefits. Now, at this point, I would like to have you, yes, we do, Dr. Rebecca. We do use Illinois Association of Medicaid Health Plans. Yes. But let me get back to, so in the chat box, if you could please answer question number 1, what is a deductible? Is it A, maximum amount of dollars that beneficiaries is liable for health coverage for that period? B, network of healthcare providers that are contracted with health insurance plans? Or C, dollar amount to be paid by beneficiary before insurance plan starts to pay? So which one is it? Is it A, B, or C? So I would like everybody to answer that question, please, because this is a poll we are doing and it's part of the assessment. So Wasan has actually a question about this. I'm not sure where if she's on there. That the having to what are pre-assessments. So these are all of this is a part of pre-assessment. So I need everybody's answer. Has everybody answered? I don't think everybody has answered so far. Okay. So what is the out of pocket for insurance? Is it A, B, or C? Okay, very good. What is a plan network? Okay, very good. Okay, so I see that people have a general sense of what these things are. So I'm gonna go some of I'll skip over some most all I can go much faster through these slides now. So understanding coverage differences, coverage limits, network limits, service limits, disease conditions, coinsurances, and copays. That is one of the things I would like to mention, that coinsurance is actually a percentage of the total cost. And sometimes the beneficiary now is a legal term, which means the person has health insurance. So they are they take the benefits of the health insurance. That's why they're called beneficiaries. So coinsurance is the percentage of a total cost, and copayments is a fixed amount per occurrence. So either the person is going to have, almost 99% of the time, they would either have coinsurance or copays. It doesn't happen very often that they would have both, but most often it's either one of them. The rest of these you guys have a very good understanding of, so I'm going to move forward. Now, premium tax credits is actually the ACA said that the IRS will pay to people who cannot afford healthcare coverage, and they would pay based on their income. So the amount of premium tax credit that a person gets depends on the actual household income as a percentage of the FPL, the federal poverty level, and I'll go over what that is. So premium tax credits and IRS premium tax credit is actually a sliding scale that increases the taxpayer's own contribution towards the premium cost as household income. Advanced payments are paid directly to the insurer, and these amounts from IRS are actually reconciled at the tax time. So you have to file taxes if you're getting a tax credit. Okay, so do people know what a federal poverty level is? It's an open-ended question, guys. What is a federal poverty level?
Is this what they use for through the census and asking everyone what the family income is?
No, they are trying to gauge people on what is their federal poverty level is. Correct. Sort of. Yeah, absolutely. Very good. Very good. Excellent. You guys have a good understanding of that. Yeah, so it's a measure of income. And so it's issued by the Department of Health and Human Services. And it's an economic measure where it decides which, and some of you has in the answers that what kind of benefits does a person gets. It's actually a confusing term. That's what most people consider. FPL is a very confusing term. Poverty level means the higher the amount. For example, 200% of the federal poverty level, really, a person is making much more than 100% FPL. So we will go over that chart in a bit. Yeah. So here is the chart. So if a single person is earning $12,000 or 12, this is, by the way, every year this chart is a little bit different. So I have the one from last year. So the single person earning $12,140 is at 100% federal poverty level. At 130, so it's $16,753. That puts them in the 138%, and $48,000 comes up to be 400% of the federal poverty level. Okay, now why is 138% or 250 or 400%? Why are these income brackets matter? That's the key. And you probably want to memorize these income brackets. As you help people, you can understand, or you can gauge which tax bracket they are in and what kind of healthcare benefits, or which bucket from of the healthcare benefit they are going to get the benefits from. So let's move further. So one of the things that ACA did, it actually made sure that the health coverage is there for all ages. So from 0 to 19, the people have choice to go into Medicaid or CHIP, or they can go into Marketplace. And this, of course, employer coverage is also available if the parents are employed for that child. Now, if the person is earning, let's go back here. If there's a household of 3 and the parents are earning about $20,780 at 100%, or up to even $28,676, their child will go into Medicaid, because that's 138% federal poverty level. And 0 to 19, up to 19 years of age, that child will either go into CHIP, or it would actually go into Medicaid. Now, if they earn up to 250%, the child will go into CHIP. So I'll actually have the breakdown further. So from 18 to 26, if the person is earning and not dependent, 18 to 26, if they are under 138%, it's Medicaid. Over 138% is Marketplace. Now, this at 100%, it's a federal law that in all of the states throughout the United States, the person will get Medicaid, no matter which state they are in. In the Obamacare or ACA, they expanded that Medicaid limit to 138% of the federal poverty level. So they said that up to 16,000, or let's see, the household of 3, up to 28,676, all of these 3 people will get Medicaid. But if they are dollar more, 677, for example, this patient will not, this beneficiaries will not go to Medicaid. They will probably go to Obamacare or ACA. And I'll tell you how that works. So under 30, you have another option of the catastrophic coverage, which is very basic coverage. Yes, so I'll get to the AGI as well. So Medicaid is so from 18 to 64 all the way up to 65, up until they are eligible for Medicare. Then a person can get Medicaid if they are below or under the 138% federal poverty level. But over 138% poverty level, they also have this option of marketplace.gov or Obamacare, whatever you want to call that. Okay. Now, people get often confused between Medicaid and Medicare. Now, over 65 gets Medicare. They also get Medicaid because they become dual eligible. That's what you want to call it. I'll tell you if I get to those slides. Otherwise, it'll be later, either tomorrow or Saturday. but we probably would not cover Medicaid or Medicare today. But I just want to make sure that I've covered enough of Obamacare and leave you with the thoughts. Okay. So, if a person comes to you, how are you going to decide what are they eligible for? Are they eligible for Medicare? Are they eligible for Marketplace? Are they eligible for Medicaid? So you have basically over here, you have income limits. If you are generally earning this is where you should go to. A lot of the times people, come to us and they say that, oh, so-and-so told us that if you don't have healthcare coverage, you can get free healthcare coverage from somewhere. And why don't you get me that? Okay, let's decide if you qualify for that, right? So what kind of coverage types we can have? Let's look how do we decide? So the household, while you are serving people or checking for eligibility for the coverage types, these are some of the basic factors that you need to consider. Household dependence. Where do you live? What's the residential status? Whether it's Massachusetts, whether it's Illinois, whether it's Florida, whether it's California, because depending upon where you live, you may have different programs or different health insurance companies available to you. These health insurance companies and the plans are very, very limited in the, or they are special to the, or specific to the geographic areas. Your work income also matters. Your work, what kind of work you do and what kind of income you have, that matters. What is your age and how do you pay taxes? That matters a lot. So these are some of the basics that you must. So, very often the very first question we get is, do I qualify for Medicaid? Or how do I get free health insurance? Well, let's check. Number one, are you insurable? Are you uninsurable? That's the key. So the very first thing in dealing with community, or when people are or when you're going out in the community, you got to understand if the person has not had healthcare coverage for a long time, there's why is that? How did they fall out through the cracks? Prior to ACA, before 2013, it really made sense. A lot of people didn't have it. But if they don't have health coverage today, then I want to know, how did they even fall through the cracks? And still to this day, 23 million people don't have healthcare coverage. But out of the 23 million, about 11 million are uninsurable. And the reason why they are uninsurable is because they are out of status residents. So I don't like the word illegal or undocumented, because that's really not true. They legally came here, but they became out of status. So they don't have a status to go to the insurance company or to go to the Medicaid or Marketplace saying that this is my status, this is how much I earn, and actually this is what I need. I need healthcare coverage. We also have encountered people in our line of work where people actually earn quite a bit, but they may be out of status and therefore they cannot have healthcare coverage. So it's not the matter of money, it's the matter of residential status. Sometimes, for example, DACA. DACA is actually a law. The DACA, the category that falls into that, this is the Dreamers Act kids. So their parents came in, they actually, they were kids when they came in. Now, if a child is born here, they're citizens by default. But if the child came in as an infant or as a child or under 18, they grew up here. This is their country. This is what they call home. But they have as soon as they became over 18, since they're out of residential status, they cannot go and get healthcare coverage by any means. And we have been fighting for under ACA for DACA, but even to this day, that is still in a pending status. Visas, people who have visas, they actually can get healthcare coverage, especially if they are earning. So the work visas, they can get healthcare coverage through the Marketplace. Green cards that have expired, even though the green cards have expired, it doesn't actually get them out of status. It's simply that they are permanent residents. It's just that their card has expired, so they just need to renew the card, and there's a fee that goes with it. Often, if they are unable to pay the fee, there is a fee waiver, but a lot of people don't know about these things. So these are all of the community assets that you can think of as you go through. We have a solution for every single problem in this country, guys. It's just that these solutions are not documented. And our effort with the asset mapping is that these solutions can be documented so people can take advantage of it. People can get benefit from the solutions that exist out there. We are simply becoming the bridge for them. That's it. Overstaying visas, those are also the people who cannot get who are not insurable. Overstaying visiting visas, overstaying F&J visas, and Hispanic immigrants sometimes if they have again overstayed or walked in or came into the country, they would be uninsurable. One eligibility process through the marketplace. So people who are insurable, what you want to do is you can simply take their basics and put them into the marketplace applications. And we actually do in the Worry Free, we do this every day. But so there is a process of qualifying them. There's an eligibility process that we walk through, so we don't waste our time on the marketplace application, because the marketplace application, there are so many variables in there, and depending upon how you fill that application out, your premium could be very high, or you could put yourself in trouble by having the coverage denied to you. So you don't want to make any mistakes while filling that application out. And some of these questions in the marketplace applications are actually baffled me even to this day. So I personally, since I don't do as many marketplace applications, no, I don't do any marketplace application these days, by the way. All of the burden is being carried by my team, the health coverage team that you saw on the website as well. So you can always reach them out too. For any reason, if you have an issue, they would be very helpful. That's what they do every single day. So it is technical. It is pretty detailed, and these questions baffle me today. Even after so many years, and what are they trying to ask here? How should I answer this question? And sometimes, I have the right answer. Sometimes I don't have the right answer. So it does take expertise to actually fill the application out appropriately. And I would recommend that, you definitely talk to the experts when you are helping then you are helping the community out there. So there are tax credits that come in every year. So but the marketplace application actually takes care of it. The reduced cost sharing and the Medicaid and the insurance program, all of that. So again, if you look at the different services, you have the kids have an option, adults low income, they have an option, adults high income have an option, adults 26 to 30 years of age, the catastrophic coverage actually can cover them. It's a very, very low premium plan. Adults less than 100% federal poverty level, they have an option. And elderly immigrants, green card, they have an option. Elderly citizens, they have an option. So ACA pretty much covers everybody. There's no reason why anybody can remain uninsured today who's insurable. Now, there are also plans like county plans that are available for the uninsurables. So even for those people who cannot get insurance through the proper channel or the mainstream, they even have options like Access DuPage, county care plans. There are other federally qualified healthcare clinics that actually help out the uninsurables. So to this day, if anybody doesn't have a medical home, I would turn around and then I ask them why. Because there is almost always 100% of the time, it is lack of health education or lack of access to care education. So let's deal with let's go over some of the very basics of the premium tax credits. I know this stuff is very, very dry, so I'm not gonna go too much in detail of this, but I'll tell you that once you start working with people, going out in the public, access to care is the number one question that you're going to encounter. So I want you guys to be comfortable with, when you talk about healthcare to anybody, you should be comfortable with these terminology, with some of the basics in access to care and directing people, or spreading the information, the correct information out there in the public. So you have 100% federal poverty level. If a person falls between 100 and 38%, they actually fall right here in Medicaid. And almost 23 states now have embraced Medicaid, which is, or expanded Medicaid, which is up to 138%. When Obamacare first came in, or the marketplace opened 2013, only 8 states out of 50 states said that, yes, they will have expanded Medicaid. But over the period of years, about now 23 states have actually embraced the expanded Medicaid, and more of them are yet to come. But it's the fight between Republicans and Democrats, and it's beyond me now. 144% of the federal poverty level, you would actually get, I think it should be 150%, or 44%. You actually would get cost sharing reductions and the advanced premium tax credits both. So cost sharing reductions means that you actually have your co-payments are lower, your out-of-pocket costs are lower. So total cost that you pay for your healthcare coverage is actually going to be lower than people who are over 144% FPL. And but up to 100 and 250% of the federal poverty level, you get the premium tax credits anyways from the government. So up to 144, you have both. You have advanced premium tax credit. You also have cost sharing reductions, but up to 250%, you have advanced premium tax credit for sure. So which means that if somebody earns, let's say, 28,000 or 22, less than 50,000, let's say, a household of 3, some of their half of, or marketplace application actually calculates it for you as to exactly how much of the amount IRS is going to pay on your behalf to your insurance company every month. And that's what gets tallied at the end of the year with your taxes. So that's what happens that's what it means with advanced premium tax credit, because IRS actually pays on your behalf to the insurance companies, and that happens up to 250% federal poverty level. Catastrophic coverage. This is primarily for people that are young, from 26 and 30. So it's a very, 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 very cheap plan. It has no out-of-pocket costs, and it only covers 3 primary care visits and preventative services. So, but it's for people who are young with primarily no, they would want to say that no healthcare conditions, but even if a person has a healthcare condition and doesn't have a higher need to go to the doctor, then this is a good plan for them. I highly recommend for those years. CHIP is the Child's Health Insurance Program. It covers some of America's uninsured, but not everybody, most up to age 18. But it has the other requirements. It's primarily for foster kids, or for parents who are earning more but yet cannot afford the healthcare coverage. So automatically, marketplace application will send their part of their kids' application to the CHIP, to the Children's Health Insurance Program. And many options. It's a state level program, by the way. Medicare. I really don't want to cover Medicare's eligibility, but I do have 5 minutes, so I want to cover just one thing. This particular graphics actually comes out from the CMS publication, and it's a beautiful way to explain Medicare. Medicare is one of the most confusing things that it could be out there. But a couple people on my team are really the experts, so I rely on their judgment all the time. But here is it in a nutshell. You have the original Medicare or Medicare in general pays only 80% of the total healthcare cost. So Medicare will never pay 100%. It only pays 80%. That's it. What happens to the other 20%? So what you do is a person or the beneficiary would go out and buy another health insurance plan to cover that 20%. And that's what's called the supplemental plan. Okay. So that's how you get covered the 80%, right? I should have another slide related to that. Now, the portion of the cost it covers, that 80%, this is what happens with an 80%. You have part A, you have part B, and you have part C. So the original Medicare, you actually, part A is for hospital, part B is for the doctor's visit, inpatient and inpatient and outpatient. So part B is outpatient, part A is hospital, and part C is actually part C combines everything, but it's part D part D is right here. So A, B, and D. D is for drug. So the traditional Medicare will give you part A for sure. And part B, you actually have to pay $150 per month. Part D, you have to buy from an insurance company. And Medicare supplemental insurance, it is there. So this is the Medicare supplemental insurance that you need for that 20%. So you piecemeal all of this and you say, wow, you still end up with good $300 worth of insurance, or actually more in many cases, even though you have Medicare. Okay. So Obamacare, or Affordable Care Act, came up with a solution. And this has been happening since 2010. They came up with Part C. They said, let's combine all of these and let's ask the insurance companies to actually come up with the insurance plan. And insurance companies sure did. Blue Cross Blue Shield offers Medicare Advantage. So that's called Medicare Advantage plan. The premiums or the monthly payment for this insurance most often comes from the federal government. And whatever the federal government gives them, the insurance companies, they actually support this entire healthcare need for that patient. So you have original Medicare and you have Medicare Advantage. At this point, I'm going to stop because I know this is a lot. We have walked over in access to care. We have walked over the basic marketplace applications. We have walked over Medicaid. We have walked over CHIP. We have walked over the Medicare options. But I know every single piece has its own delivery of services. And it takes, that's part of the reason why anybody who wants to do access to care, it takes good 3 years for them to become an expert in what they do. And you just have barely, gotten to the tip of the iceberg here. So with this, I'm going to pause here up until this point. We will upload the slides, and the rest of the material, I will actually cover it in the rest of the sessions, because I know this is dry material, and I don't want to overload you guys, because you guys are going to say, that gives me a headache. So next tomorrow, we would actually go on with, let's see, where did my tomorrow's slide go? 5 and 6, we would actually work with Intro to PCORI methodology and research project, and community engagement and advocacy. So a little bit I would cover in the community engagement. Perhaps I can cover some of the materials with how do you engage with the community with access to care, and how do you advocate for somebody who does not have healthcare coverage at all or is uninsurable. And in session 6, Oh, this is actually session 5. That's what we would cover, inshallah, tomorrow. And then we would do a little bit more on the PCORI methodology and access to care on Saturday as well. And Saturday we would also have one of you, it's a surprise, one of you is actually going to be sharing their community health grassroots efforts. That's what they're having, what they're dealing with in the community on Saturday. So I'll leave you that with the suspense. At this point, I want to ask if anybody has any questions.
This is Rebecca here. I just want to say thank you, Fatima. That's amazing. Absolutely amazing. I can totally see why it takes 3 years to, but that's knowledge is power, isn't it? Knowledge is power.
Definitely. Definitely. Yeah. It's very confusing. So a regular person can't understand this. You can't ask them to be health literate. We have made that system so complicated.
Yeah.
I agree. Thank you. This is the first time I've ever seen anything like this in all of my studies, and even trying to figure out my own health insurance and how to apply.
Yeah, Andy, because a lot of the times the sessions are not, or the material is not presented in all of this context, in the bigger picture, actually.
There is some questions, Sister Fatima. There are some questions in the chat if you wanna.
Oh, okay. I'm looking at it now. Why did they make this so complicated? Oh, tell me. I keep asking the same question. It's really slowly it has come about, because, and again, we live in a capitalistic society, and pretty much the insurance industry is a capitalistic industry. This is the battle, that should the government take entire control of the healthcare system, and that's why we need to be engaged in these policy decisions. So that's the battle. Original Medicare covers Part A, B, and D, and Medicare Advantage covers only Part C. Part D, actually, Part C covers Part A, B, and D altogether. So we can go deeper into it as we uncover the Medicare. So Part A, B, and D, A is for hospital, B is for doctor, and D is for drugs. And Part C is a choice plan, so it's called Medicare Choice. And by default, Part C has both A, B, and D in there. Any other question? Yeah, that's what Bernie Sanders wanted to have, and I really would love to see that system. Really, having a Medicare for all, or having the unified system. Medicare for all, I don't know if that's the right terminology, because Medicare itself pays only 80%. So I want to have a better system than that. Yeah, so no, the 20% is actually not Medicare Advantage. Medicare Advantage is a Part C plan. So the original Medicare actually has the 80% and 20%. Now in Part C also covers that 20%. So if you can either keep traditional Medicare, or you can take Part C. One or the other two. But when you take a choice or a Medicare Advantage choice plan, then the 20% is lumped into Part A, B, and D. So it comes out to be better. Medicaid for all, then, yeah, that's what I like to see. Medicaid for all. That's what I said. Instead of having, there's a difference between Medicaid and Medicare, though. Medicaid is a state program, whereas Medicare is a federal program. We haven't covered that part. So there are two different venues of funding there. Okay, you can always shoot me questions if you feel in your emails, and hopefully I get to talk to a few more of you in the next few days. It would be Asna, the insurance companies will love you. Medicare Advantage for all. Yeah, seriously. That would the insurance companies will love you, by the way.
So in terms of advocacy, Fatima, should we be focusing on the insurance companies?
I really don't know. I don't know which way to go at this point. Number one, I really, the biggest battle is, should the healthcare system or the health payer system be residing in the hands of government?
Okay.
And that's because it's a fundamental right. But this entire premise of this country is based on capitalism.
Yeah.
And we are talking about $3.5 trillion economy, guys. $3.5 trillion. That's what we are talking about here.
Hello, Dr. Johnson, since you came from England, can you share like your experience with the NHS and compare it to our health system over here?
That's familiar. Well, yes. Well, basically, you pay part of your taxes that you pay for the national health insurance, and the idea is that everybody has access to basic health care. But it gets complicated because that means you can go to your doctor, and it means that you can expect treatment in hospital. But the system decides what drugs the NHS purchases the drugs, so you don't have that. It all gets sort of decided by government, and so it will decide the costs of those. And so if you have rare diseases, it's not a good system to be in, because sometimes they will decide that it's too expensive for the national health system to cover. So there are issues, and the big issue is actually there's a difference. It's very good at covering hospital care, but in 1945, when it first came in, they didn't cover social care, and that was a big issue. So particularly with the growing sort of older population, you have situations where you have an older person who goes into hospital for their hip replacement, and then they're just expected to sort of leave. So there's no joined up thinking between the care you get through the hospital and the social care. But that's a sort of global problem as much as anything else. But the care you get in hospital is great, really good, and it's freely available to everyone. And so the way it works is you join a GP, your local GP, and you go and see them, and you make an appointment with them, and then they would refer you to whatever hospital that you're needed. But there are a whole series of things which are not covered by the NHS. So there are physical therapy, for example, social care, as I mentioned. Those are things that and my mum keeps me up to date on what's going on at the moment. And she said that she having to pay for simple things like having her ears syringed or her toenails cut, those sorts of things, which British people have not been traditionally accustomed to paying for. My experience of the healthcare system here is odd. I've actually had to wait a long time to see a doctor, and it seems to depend on what condition you had. So the other day, for example, I realise I'm extremely lucky to have insurance, and I'm very grateful that I do have insurance. But the other day I bent my fingers back, and I have what's called mallet fingers. The dangers of fitted sheets, so watch out for fitted sheets. And I had to wait ages. So the hand therapy and the guy had a whole team. Whereas other times I've gone for other things, and there's been one person who's dealing. So I don't quite understand. There seems to be a priority of conditions here as well in terms of.
Yeah, that's not really often brought up. Absolutely, yeah.
But thank you for asking, because it is fascinating from my perspective. Really interesting. Yeah, different. I mean, as a researcher, obviously it's not a joy to experience, but as a researcher observing it, it's very interesting, the differences. Yeah. Very good.
Excellent. Any other question, guys? I know we are running way over our time. So I'll give it a moment if any of you have any questions. Otherwise, we will, inshallah, see you tomorrow at 5.
Yeah, thank you so much, Fatima. That was awesome.
Thank you so much, Dr. Johnson. Thank you so much. Thanks, everybody.
Yeah. Okay.
Yeah.
I'll see you again.
Thank you again.